Welcome to RAQD Clinic. Hi, I'm Jack Cush with Room Now. Today's case, the RAGI Fast Track. This is sort of a retrospective piece. I came across this note on a patient that I've been following for over 10 years. The gentleman is now 30 years old. He was diagnosed with seronegative rheumatoid arthritis back about 10 years ago. He had polyarthritis, negative serologies for RF and CCP. He did have high levels of stiffness and sed rate 70 CRP with 8 milligrams per deciliter. And he had involvement of, at different times, hips, knees, ankles, wrists, and usually at any one time, 2 to 4 joints active. He has bounced in and out of my clinic over the last 10 years. Some might say he's non-compliant. Some might say he has intermittent disease. Others might say he's a young student who has no insurance and is bothered by all the bills. And the question is, how do you handle this gentleman's treatment, evaluation, future care, and the big issue of noncompliance, because that's clearly in play here. So when I see him, the last time I see him, he presents with arthralgias. He had been about 6 to 8 months ago, I had given him some samples of golimumab. He has been treated over the years at various times, largely with samples, sometimes with a patient assistance program. He's been treated with prednisone, methotrexate, hydroxychloroquine, nonsteroidals, tocilizumab, adalimumab, sulfasalazine, and most recently, golimumab. And generally the TNF inhibitors have worked in him. The IL-6 inhibitor didn't. I'm never quite sure if the methotrexate or Plaquenil worked. I'm never sure that he really took them. But now he presents with stiffness, some arthralgias, mild stiffness, mild to moderate arthralgias, denies any swollen joints, but is having weight loss again. He's had it before, and now bloating without diarrhea. He denies diarrhea or bloody diarrhea. I have previously suspected him of having colitis. That was occult and the cause for his arthritis. And the question is, what are we going to do now? We're just going to refill his golimumab. We're going to read him the Riot Act about coming to clinic. I've told him many times in the past, you're not my patient unless you come every 3 months. I'm not going to, if you have no money, I don't care. I'm not going to charge you. If you have no money, I don't care. I'm still going to get you drugged. You know, this needs to be treated, and no one's going to be treating it any better than I will. And then maybe you need to consider, you need to go to the GI doctor, and he had not done that as yet. So anyway, at this visit, I strongly again suspected that he had colitis, probably Crohn's disease, and told him, here's 2 syringes of golimumab, and you have to go. You know, he is quantiferon negative, hepatitis testing negative. He has a normal labs on exam. He doesn't have any swollen joints today, but he has 4 tender joints. But he has the signs of prior damage. He's got a hallux valgus deformity bilaterally, mild elbow contractures indicating past inflammation in his elbows, some limitation in the left wrist. So the challenge here is getting him in to see the GI guy. That's first. That's why he's a fast track. Why am I worried about this? One, he's had intermittent GI complaints, mostly bloating, sometimes weight loss, a little bit of diarrhea, but no bloody diarrhea, no mucousy diarrhea, vague abdominal pains, and he's seronegative. Remember, we said in the past that an RA patient who is seronegative is your invitation to reconsider the diagnosis at multiple times, if not at every visit. And could it be something that can mimic RA, like enteropathic arthritis? So that's why he needs to be on the fast track. I don't want to pump him full of steroids and give him a limitless supply of TNF inhibitors because he'll never go. So then I have, and then anyway, why does he have to go to GI? Because he needs the evaluation. He needs to be scoped. He needs a biopsy. He needs to be on the right therapy. And maybe if this is enteropathic or Crohn's-related arthritis, then maybe he'll do well on vedolizumab, the integrin targeted drug. Obviously, TNF inhibitors have worked in him in the past, but they have a whole bunch of new drugs besides vedolizumab. They have natalizumab. They've got ustekinumab, the 1223 inhibitor, and also the IL-23 inhibitors will work well, and also now the JAK inhibitors. So there's a number of drugs that are some better. Vedolizumab is much better at the GI complaints than it is at the arthritis, but if that's the dominant problem, bingo. If he's got a dominance of both arthritis and the GI stuff, the Crohn's disease, well, then we're going to have to work together, GI and rheum, in the co-management of this case. Lastly, young people and compliance is a real challenge. Number one, just only give them enough medicine till the next visit. Don't take away all the impediments they're coming in as much as you can. I could, at that time, see him no charge in my clinic and get him medicine for free, either through compassionate use or through samples, right? You can also control on compliance by only giving him medicines that are infused in the clinic or in the infusion suite, right? So that could be infliximab over adalimumab, for instance, right? And then, if you have the ability to check blood levels, to look at that as a measure of compliance, put that into play. But really, this is strong communication and getting the young person who doesn't want to be ill, doesn't want to be labeled with a diagnosis, doesn't want to be anchored to a chronic therapy. This is a big challenge, as this patient's history has shown us. Hope you enjoyed this QD Clinic. QD Clinic is sponsored by BMS, the sponsor for the Hard Decisions in RA campaign.